Hello, my name is Ann O'Day, and I am a breast medical oncologist at the University of Kansas Health System. And I am very honored to be able to moderate our first case today, in which we're going to be discussing a young woman with a diagnosis of breast cancer. We're going to explore some of the quality of life issues, fertility preservation, and sexual health that pertains to our young breast cancer survivors. I'm going to quickly introduce our panel of experts here. I'm joined by my partner, Dr. Lauren Nye, also from University of Kansas. Kelsey Larson, who is one of our breast surgeons here at KU, Dr. Kristin Holoch, who is also with KU and is an expert in fertility preservation, and Dr. Danielle Staecker, who is an OB/GYN with KU as well. So thank you all for being here, and I look forward to hearing your insights. So we are going to dive right in with our case here. This is a young woman. She's a 30-year-old patient who is actively being followed in our high-risk breast clinic. She has a known family history of hormone-positive breast cancer that was diagnosed in her mother at the age of 35. And her mother has a known pathogenic variant in PALB2. Our patient has been recently married and is planning a future pregnancy, but she has not yet undergone genetic testing. She has a screening breast MRI, which demonstrates a 1.6 centimeter irregular mass in the right posterior outer breast. There was a correlate seen on the right ultrasound, and she ultimately underwent an ultrasound-guided core needle biopsy. And the pathology demonstrated an invasive ductal carcinoma that was moderately differentiated, estrogen receptor 95%, progesterone receptor 95%, and was HER2 negative 1+ by immunohistochemistry with a Ki-67 of 25%. So we have our very young patient who at this point we would like to engage our breast surgery colleagues. And so we're going to ask Dr. Larson, can you just kind of comment for us when you're sort of confronted with a very young patient who hasn't yet had the opportunity to have any children, was just recently married, sort of in the prime of her life. What's the discussion that you sort of have about the different options for breast surgery? And are there any particular nuances of this that you sort of discuss more with your younger patients, particularly understanding that she's a patient that has not yet undergone genetic testing and she has a known pathogenic mutation in her family?
Yeah, thank you. So, the young patients that we see with breast cancer are often falling into one of two categories. So we often see patients who come in who say immediately, I want bilateral mastectomy. And we often have patients who come in who say, under no condition am I getting a mastectomy. And both of those can really be the right choice depending on which patient we're seeing. So the key factors that we need to remember is that the breast cancer prognosis, whether a patient is 30 years old or 50 years old or 70-year-old, does not differ by more or less extensive surgery. So just because a patient is younger and is 30 years old does not necessarily mean that they need a bigger or more aggressive cancer operation. And so one thing that some people think is because I'm younger, I have to have a mastectomy. That's not the case. Lumpectomy and mastectomy are both safe options if offered to the right patients. In addition, we want to really consider and talk to patients about aesthetic concerns when they're picking their surgery. So if they are interested in a lumpectomy, we want to make sure that we're offering them the oncoplastic tissue rearrangement so that they have a nice cosmesis after. And we know that when we can offer nipple sparing mastectomy, which is safe as long as the cancer is far from the nipple, that this is better psychosocial functioning and really does a lot for patients in terms of being proud of their aesthetics and pleased with their cosmesis after surgery.
Dr. Larson, can you comment a little bit more, just expand on this whole field of oncoplastics and kind of comment about how that is different and unique from simply just our breast reconstructive surgery that we're traditionally used to?
Sure. So oncoplastics is the idea that alongside every cancer operation we do, we should not just be removing the cancer, but we should be considering the way that we can do this in an aesthetically nice manner. So we want to pick scar placements that are hidden, whether it's along the inframammary fold or along the periareolar border. We want to make sure that we're doing tissue rearrangement, so we're filling in that gap or that defect that we leave. So what I tell people is that while you're going to have a scar, my goal is to make your scar as least visible as possible. And you should not have any ugly divots, dimples, deformities in the breast. We want a nice aesthetic shape and appearance to the breast when we're finished with the lumpectomy.
Perfect. Can you talk a little bit, Dr. Larson, about how you talk with your patients about the differences, whether you are able to do breast conservation versus mastectomy, whether or not it's nipple sparing? Can you talk about the differences in sensation and the difference in sort of numbness or, what patients might experience with the different operations?
Sure. So after mastectomy, we tell patients to expect that the skin of the breast, and if they keep their nipple and areola, that as well, is numb. And some people have some very light sensation. They feel like they can feel a sense of touch or some sense of clothing or things brushing against it. But for most people, it's numb, and it certainly is different. That's something that's permanent. And the best mental image I can give to patients to describe why is because the innervation to that skin comes through the breast tissue. So if I remove all that breast tissue, that innervation is gone. With a lumpectomy, they often have some decreased sensation right around the scar and sometimes right around where the tumor was removed. But in general, the breast sensation overall would be about the same, just around that surgical area. So that is one thing that's very different for patients.
Perfect. Thank you so much for commenting on that. I know in my own practice that that's something that comes up with patients over the longer term. It's something that initially is not maybe in the forefront of their mind. And then as they sort of go on and experience life, they'll often comment to me, I didn't have a full appreciation of exactly how numb, or the degree of numbness that they would be. And that affects everything from their ability to, hug their partner to holding a baby to sexual arousal, all of those things are issues that we see kind of be affected. So I appreciate you commenting about that. Dr. Nye, can you guide us through, when you have a young patient like this, a 30-year-old woman who's obviously not only worried about curing this breast cancer, she's worried about, what is her future risk of developing a whole new breast cancer? How do you talk to women about what their risk is moving forward and helping them understand what an accurate assessment of their future risk is?
So I usually use the risk estimates in somebody who does not have a genetic mutation or hereditary breast cancer syndrome, the risk estimate of about 0.5% per year risk of getting a new breast cancer in their lifetime. And I think it's really important to differentiate between recurrence of their breast cancer and new breast cancer. So having to deal with this all over again, it's about 0.5% per year. So in a 30 or 35-year-old, that could be a 15 to 20% risk over the next 30 to 40 years. But in a 60 or 70-year-old, that risk would be much lower. And then somebody who does have a pathogenic variant or a genetic mutation that increases the risk of breast cancer, specifically if it's BRCA1 or 2, then we know that their risk of having another new breast cancer in their lifetime is higher and closer to 1 to 2% per year. So in somebody in their 30s, that could be a 30 to 60% chance of getting breast cancer again in their lifetime, which is quite high.
Perfect. Thank you so much for quantifying that. I know patients often share with me that they tend to overestimate, what their risk of a future breast cancer might be. And that obviously can have implications when they're working with their breast surgery team about, what might be the best surgical approach for them. So I think helping to really quantify that is critical.
Sorry. So the other thing to go along with that is that remember that after mastectomy, your risk of breast cancer is not 0. So it's a risk reducing mastectomy. It's not guaranteeing anything. And I tell people, if I could guarantee no one got breast cancer again, everyone would just come and get a mastectomy, right? No one wants to deal with that. But the risk of cancer after a mastectomy, even a risk reducing one, is 3 to 5% lifetime. So as Dr. Nye was saying, people overestimate what their risk might be, but they also tend to overestimate what surgery can do for them.
Thank you so much for pointing that out. Can you talk for us a little bit about the other aspects of local treatment and how, the choice about what approach they employ for breast surgery is going to impact their need for radiation down the road?
Yeah, absolutely. So surgery is one aspect of local treatment, but it's often not the only local treatment someone needs. So the phrase I like to use is that lumpectomy and radiation are partners. They go hand in hand. So if we're moving forward with lumpectomy, then we've committed to getting radiation as part of our cancer treatment. And especially for young women, there's never an instance where they would not need radiation after lumpectomy. Patients who undergo mastectomy sometimes do so trying to get out of radiation. And often that's not a bad approach. So a lot of people do not need radiation after mastectomy, but it's not a guarantee. So some general categories where people may still need radiation after mastectomy are things like inflammatory breast cancer, larger tumor size, lymph nodes involved, or invading into the chest wall or muscle. So if we don't see these things on their preoperative imaging, that's a great sign that you won't need it, but we don't know 100% until we get that surgical pathology report back from their operation.
Perfect. Thank you so much. All right. So for our particular patient, ultimately, she decided to proceed with a surgery first approach as her first step for treatment. And she elected for bilateral mastectomy and right sentinel lymph node biopsy. And she definitely expressed a desire for future pregnancy. And so that's something that we're going to discuss. We're going to discuss here with Dr. Holoch. So Dr. Holoch, if we can ask you, you are so helpful for us in working with our younger patients who desire a future pregnancy. Can you talk to us a little bit about what that conversation is like when you sit down with a young woman with a recent diagnosis of breast cancer? In the case of this woman, particularly, she hasn't had the opportunity to have children yet at all. So how would you approach this conversation?
Yeah, we typically get consults from the cancer center, not just breast cancer center, but kind of anyone who's approaching treatment or cancer diagnosis. And kind of the initial discussion has to do with what their choices are. And the sort of the best, if they're able to, is to do essentially an IVF cycle where we give them medications to stimulate their ovaries, trying to get those eggs to grow, and then take out those eggs in a surgical procedure called a retrieval. And at that point, they can choose whether they want to fertilize the eggs and make embryos, or whether they want to just freeze them as eggs. It's an important conversation and something to think about, I think, because initially patients are really consumed with their diagnosis and they really want to get moving on treatment. But I always tell people, if your team is on board with this, and we do work with the team and make sure everyone's okay with the timeline, but I just really want the patient to be able to make the decision on their future fertility and whether they want children or whether they want to grow their family and not have their cancer make that decision for them. People always wonder, how long is this going to take? What's it going to be like? And I think it's surprising to a lot that it's basically a 2-week process. We can see patients the same day. Often some of my colleagues over there at the cancer center call and say, can you see this person today? And we really make an effort to, but very quickly. And we have the means to get someone started that very same day if they need to and if they're really interested. But from start to finish, growing eggs to getting the eggs out would be about 2 weeks. And people worry also about the cost. And I think, of course, it can be expensive, but it's something that the university, I think, really tries to minimize the cost upfront for people. If patients qualify for programs such as Live Strong and Heartbeat, those are some organizations that provide medication for free for people with a cancer diagnosis. They also have the opportunity to make payments to the university over time, versus if they were just presenting to our office for fertility treatment without a cancer diagnosis, all that cost would be due up front. Another thing I mentioned is the coordination between the cancer team and the fertility center team. The one major goal is that we don't want to make anyone's survival worse, by doing anything. And we want to be all on the same page with their oncologists and breast surgeons and make sure that everyone's aware that that 2-week time frame is needed. And we can stay really close to that, like if someone's like, she needs to start chemotherapy on the 18th, we say, okay, well, your retrieval is going to be the 18th or before, and we can send you straight to the cancer center to start chemo like the day of your retrieval. So that can all happen pretty quickly. And the risks of stimulation and retrieval, a next slide shows kind of a picture of what a retrieval is. And essentially the ovaries here are those white kind of lumpy things there, and those are kind of reminiscent of stimulated ovaries, and all those little cysts should be follicles, and hopefully there's an egg in each one of them. Now patients are put to sleep, and they're given a little bit of IV sedation, and this all happens in our office. And then a transvaginal ultrasound probe is used to look at each of the ovaries, and then a needle goes through the corner of the vagina into each of those follicles while you're sleeping, and we collect the eggs. The fertilization and embryo development all happens in the lab, and there's even an option to test embryos for genetic disorders, for carriers for different mutations like you mentioned this patient has.
Thank you so much, Dr. Holoch. So what I'm hearing from you, and I think this is something that I've learned from you, kind of throughout sharing many patients together, is that it's so critically important to get you and the fertility team involved, right away from the beginning, because we know that whatever treatment that we're doing or considering, that it might have an impact on that woman's future fertility, right? And so as a general recommendation for all of our younger patients who want to grow their family or be able to have a future pregnancy, that you really want to be involved, right from the very beginning. Is that a fair statement?
Yeah, I think at least to have that conversation, and to let the patients know what's available and what the options are, and then to just really allow that decision to be theirs.
Perfect. Thank you so much. I'm so grateful for your insight. Dr. Nye, do you want to comment a little bit about, this was something that just came up in my clinic today, a patient who had a hormone positive breast cancer a few years ago called our office, and lo and behold, she's pregnant, and she's asking, what does that do to my risk of recurrence of breast cancer? And so how do you talk to your young patients about that who are our breast cancer survivors?
Thank you. Yeah, I have 2 patients currently that we're kind of in planning for this process right now. And what we know is mostly based on retrospective data, which in oncology is not our favorite kind of data, but what we know is that in women who've had breast cancer, specifically a hormone positive breast cancer, and then get pregnant after treatment for that breast cancer, we don't see worse outcomes for the breast cancer. So we don't see higher recurrence or decreased survival in women who've been pregnant after breast cancer compared to women who have not. There's an ongoing prospective trial to specifically answer this question for us that we're eagerly awaiting. And it is close to accrual, but we don't have the data yet. Now we're just waiting. But it included stage 1 to 3 hormone positive breast cancer survivors ages 18 to 42 who were premenopausal at diagnosis and who've been on endocrine therapy for at least 18 months. And the plan is to allow them to take a 2-year break, or up to 2 years, off of the adjuvant endocrine therapy to achieve pregnancy. And they're being followed for outcomes, so recurrence of breast cancer. And so I think this will be really informative. I still worry that it's several years away, and we have women dealing with life right now wanting answers to this question. So we just have a realistic conversation right now about what is the risk of recurrence. While I don't think pregnancy will change that risk, I usually explain if the cells are there, the cells are there. But if somebody's very high risk for a recurrence, then I think that does give us some pause and some discussion to talk about is the best way to achieve a family for them to carry the pregnancy. versus considering alternative options such as surrogacy. But for most women, the data supports that their outcome is not worsened by pregnancy.
Dr. Nye, can you talk to us about how you would approach the planning for her systemic treatment?
Even though she's 30, my next step would be to consider using the Oncotype based on her pathology or a different genomic test to guide the chemotherapy decision as the next step. Oh,
Sorry,
I was going to say, it looks like her Oncotype came back 21, which falls into that intermediate category.
And so how would you go about choosing, which chemotherapeutic regimen would be your preferred choice?
So in a young woman with an intermediate oncotype, and we discuss this a lot at tumor board, it's really a conversation about the risk of recurrence and the benefit of chemotherapy. But for someone with this higher intermediate oncotype, I would favor chemotherapy if the patient was agreeable, and I would lean towards TC for her since her lymph nodes were negative.
Okay, perfect. And do you want to comment for us a little bit about some of the data? There's a lot of controversy between anthracycline-based regimens compared to, taxane-based regimens, and whether the anthracycline can actually be omitted. And we have a session later today about the cardiotoxicity of, and how we can improve things for patients in terms of their future cardiac risk. So how do you go about deciding which are the patients that can forego anthracycline?
And so we look at the data that we have that combine the trials that used regimens like TC compared to the trials that used regimens with an anthracycline. And we saw a very small benefit to the anthracycline-based regimens. And when you break that down, that benefit is mostly in the hormone-negative breast cancers, and more specifically our triple-negative breast cancers, and then in the lymph node positive breast cancers. So I would tend to favor an anthracycline-based regimen in a young woman with positive lymph nodes. But if I can, I would spare that anthracycline in someone with negative lymph nodes.
Perfect. Thank you so much. So ultimately for our patient, the breast oncologist and the patient decided on systemic adjuvant therapy. She was started on ovarian suppression with goserelin. That was started concurrently with her chemotherapy. She receives 4 cycles of docetaxel and cyclophosphamide. And following chemotherapy, what would be your recommendation for her adjuvant endocrine therapy?
I would favor ovarian suppression and an aromatase inhibitor in a young woman who required chemotherapy based on some of the data from SOFT and TEXT, which showed a small benefit, but a benefit to ovarian suppression in premenopausal women, especially those at higher risk, and then a slightly increased benefit to an aromatase inhibitor over tamoxifen.
Mm-hmm. What do you feel like, you touched on the SOFT and TEXT trial, and we don't, have the time today to delve into this data, but how do you feel like the quality of life is for patients when you add ovarian suppression to their adjuvant endocrine therapy?
I definitely think the quality of life is worse. It's more difficult with ovarian suppression and aromatase inhibitor, especially in young premenopausal women. But I usually start my conversation with, this is where we can start. And if we have to pull things away, we can. We can go to ovarian suppression and tamoxifen as the next step, which is usually a little bit more tolerable. And then in the end, if we just don't tolerate the ovarian suppression, we can also pull that off as well. So I make sure they know that there's options out there, and we'll manage their toxicities the best that we can.
Mm-hmm. Okay. Yeah, I really appreciate you sharing that, because I know that I have some patients, I will never forget, kind of the story. I have one patient that shared with me, and she said, had she known how severe the toxicity would be with the ovarian suppression and the endocrine therapy, the day that she was diagnosed with breast cancer, she would have jumped off a bridge. And that is just, it's so heartbreaking. But she was really trying to help me understand, the severity of her toxicity, the detriment to her quality of life. And so that really opened up a discussion for us about, where we could go for her and how we could try to improve things. So I do think it's worth mentioning that although we certainly have this goal in medical oncology to minimize cytotoxic chemotherapy and minimize the toxicity from that we know that the ovarian suppression, especially when combined with an aromatase inhibitor, that's going to come with a significant toxicity as well. And for our particular patient, what she shared is that she started struggling with hot flashes. Those weren't tremendously bothersome. She was just having 1 to 2 per day, but definitely started to notice decreased libido, and that was very bothersome for her. So Dr. Staecker, I might ask you to just comment for us a little bit more about how you go about approaching women who do start to experience these types of symptoms, and when you encounter these patients in your clinic, how do you help them sort out, where all of this toxicity is coming from, and how do you go about tackling that for them?
Sure, I get asked about libido often, and libido is multifactorial. There's not a single pill that you can prescribe that will solve the problem. There may be certain biologic or hormonal aspects to why it's low, whether she's going through iatrogenic menopause or natural menopause. All women will experience to some degree genital urinary syndrome of menopause, which is a constellation of symptoms involving the vulva, vagina, and bladder due to a low estrogen environment. And this can cause painful sexual activity. In our patient, certainly the aromatase inhibitor is contributing to the severity of her symptoms. And painful sexual activity also leads to the anticipation that future activity is going to be painful as well, which further suppresses libido. So in other words, if sex hurts, you're not going to want to engage in that activity.
Right, unfortunately, right?
Yes, unfortunately. Interpersonal relationships also play a role. So patient and partner who may develop, he may develop a fear of causing pain or anxiety about causing pain in that patient. And on the next slide, addressing and treating the causes for painful sexual activity will positively impact libido because sex doesn't hurt anymore. And I usually start with education, going through anatomy with the patient and then what's actually happening physiologically in her situation on these aromatase inhibitors or in menopause. Counseling and sex therapy is also a very important role. There are sex therapists, and I have the website listed here, that do cognitive behavioral therapy, which makes a big difference. First line treatment are lubricants and moisturizers, both moisturizers for vagina and vulva, as well as personal lubricants for sexual activity.
Dr. Staecker, can you just comment for us about the difference? Because I often try to explain this to patients and how we need both of those things and that they're complementary. Can you just really quickly explain to us the difference?
Sure. So in menopause, on some of these adjuvant therapies, your skin becomes very dry. And that happens to the vagina as well. And it is important to moisturize the vulva every day because that's the most delicate skin on the body. I tell them even more delicate than your face, and they're probably moisturizing their face every day. Vaginal moistures also are very important because there is vaginal dryness with menopause as well. And most of the moisturizers you only need to use twice a week. They last for days and days. Personal lubricants are specifically for sexual activity. And a lot of them, in choosing one, you want to have the right pH. So a pH in the vaginal range between 3 and 4.5, and then the right osmolality so that the personal lubricant is actually hydrating vaginal cells, not drawing moisture out of them.
Perfect. Thank you so much. And I know we all look forward later on today to your talk. You're going to have a whole session in which you might be able to, explore some of these things in a little bit more detail. But thank you so much for sharing your insight, because I know that this is an issue that we struggle with patients, on a daily basis in our clinic. And so with that, all of you, I want to thank you so much for your insight today. We want to encourage anyone who is watching to type any questions that you have into the chat box, and I'll be happy to respond to those, and we'll get you any answers that you need. So please feel free to type any questions into the chat box, and we will respond to those right away. And we want to thank you again for joining our session this morning, and we want to encourage you to stay tuned for the rest of the day. Thank you all, panelists. I appreciate it. Thank you.